is Dr. Sanjeev Arora. Dr. Arora is the founder and director of Project ECHO, a non-profit that uses technology, a disease management model, case-based learning, and a web-based database to arm primary care providers with the knowledge needed to treat those with complex health problems that would otherwise need to travel to medical care. Project ECHO was developed to improve both capacity and access to specialty care for rural and underserved population through service delivery, education, and evaluation. ECHO is a hub and spoke model and currently operate with hub in 39 countries and spokes in over 125 countries. Over 78,000 health and education professionals have participated in ECHO telemonitoring network. Dr. Arora is also a distinguished and Regents Professor of Medicine with tenure in the Department of Internal Medicine at University of New Mexico Health Sciences Center. Dr. Sanjeev Arora is unmuted.
Ji.
Please go ahead.
Thank you again for this great opportunity to be here and speak to your wonderful audience. And I'll be talking to you about Project ECHO. And ECHO stands for Extension for Community Health Outcomes, and our mission is to democratize implementation of best practices for healthcare to underserved people all over the world. Our goal is to touch the lives of 1 billion people by 2025, and I'm really grateful to one of your organizers, Dr. Asad Chowdhury, for taking up a leadership role for ECHO in Pakistan and for the amazing work he has done. So why do we need to expand ECHO in Pakistan is best highlighted by this paper that came out in September of 2019. It is estimated, according to this paper, which was a conglomeration of a lot of data that by Dr. Sarwat Mahmood, that 12.9 million people who were infected, 8.7 million have chronic infection. This is slightly higher than the previous estimate of 6.7 to 7.8 million, but still I think it's in the ballpark. We can say about 7.5 million people are infected. I've asked Dr. Chowdhury, and his estimate and others based on pharmaceutical data is that less than 2 million people in Pakistan have been treated. Now, even if we were to give a very conservative estimate that lifelong mortality of hepatitis C is less than 20%, we would still find that there are 5 million, more than 5 million untreated people, and 1 million excess deaths would occur. So it is mandatory for us to treat every single person in Pakistan who has hepatitis C, to diagnose and treat them. And my estimate is right now, just looking at our work around the world, that hepatitis C treatment is one of the most cost-effective things we can do in the world today to save a life, rapidly save a life by curing hepatitis C. And I'm sure all of you are doing that. So the key strategy we use in Project ECHO is to move knowledge instead of patients and providers. And I was facing this problem that we are describing, that I'll be describing to you in 2003 in New Mexico in a very robust way. It was interferon ribavirin treatment. I'm a gastroenterologist like you. We had treated 1,500 patients in New Mexico, where I live in the Southwest United States, where there were 28,000 patients who had it. And they were coming to see me. They had already developed liver cancers. They were dying of liver failure. People were driving hundreds of miles to see me, and I could not figure out how to get them all treated. So I developed ECHO with 4 key ideas. One is to amplification. I said I would use technology to leverage my expertise to bring treatment to everyone, but also the expertise of a pharmacist and a psychiatrist because of interferon central nervous system toxicity. So I had my protocol, which is the AASLD protocol, and I went around the state of New Mexico and set up 21 new centers of excellence for treating hepatitis C with interferon ribavirin. And what happened was I gave them the protocol, but not a single one of the patients was willing to, not a single one of the doctors or nurse practitioners was willing to treat hepatitis C based on the protocol. They said, this is too toxic, we are not used to it, we are not trained on it. So I asked myself, how did you become an expert? You were not born that way. And when I did my fellowship in Boston and Massachusetts, I would see a patient present to my professor, see another one present to my professor, and after 2 years, they started calling me a gastroenterologist. So I said, aha, I'm going to use this model to create new hepatitis C ologists in New Mexico, new experts, so that I could treat all 28,000 patients, and that we would use a web-based database to monitor outcomes. We call this model iterative guided practice, very much like you learned in your fellowship programs. So in 2003, I started my first ECHO program where all 21 of those sites would join together on an interactive video network and one by one present patients to each other in a de-identified way without their name or anything, but just the case stories. And I would ask everybody else on the network if they had any questions, and then we would discuss the case. And in 2 hours, we would discuss about 8 to 10 cases, and I would give them a 15-minute lecture on some aspect of hepatitis C. And as I did this week after week, a few things happened. First, the weight in my clinic started falling. It was 8 months, and in 18 months of doing this, the weight in my clinic fell to 2 weeks. Thousands and thousands of people got treated, and we were finding high cure rates. We started doing research, and what we showed was that ECHO was producing joy of work for these rural clinicians. It was reducing their professional isolation. It was enhancing their professional satisfaction. It was increasing their self-efficacy, and their knowledge base was going up simultaneously. We then did a study which we published in the New England Journal of Medicine. It was on interferon ribavirin treatment in the prisons and rural areas with the ECHO model. And we were able to show that the cure rates for genotype 1 were identical in the prison and rural areas versus the university. And for genotype 2 and 3 also identical, but we were able to improve access to care for minorities. Now we knew we had a model that could fundamentally change the world for many, many diseases. So we said we would do force multiplication all over the world. That is, we knew 6 billion people in the world didn't have access to the right knowledge at the right place at the right time. Millions were dying. And so we said, what if a nurse practitioner could give the same level of care as a specialist, which we had shown in our New England Journal of Medicine paper? Then we would get 10 times expansion in capacity. And since we had gotten 10 times expansion in New Mexico, we started using it for a lot of other disease areas like antimicrobial stewardship, autism, bone health, cancer, chronic pain, lung disease, diabetes, education. We used it in education to mentor school teachers to be better teachers, just like we were mentoring primary care doctors. Hepatitis, of course, B and C, high-risk pregnancy, addictions, opioid use disorder, quality improvement methods, sexually transmitted diseases, tuberculosis, HIV. The primary reason for doing ECHO was because medical knowledge is increasing exponentially. And every 3.5 years, it doubles, as according to this paper. And a primary care doctor living in a rural area cannot keep up, and you need a different way of spreading knowledge. This is the Veterans Administration ECHO network, 9 university hubs, 600 clinics are connected for 39 disease areas, including hepatitis C. This is US Department of Defense ECHO with hubs in Belgium, Germany, Italy, Japan, South Korea. And we wanted to help 1 billion people. And so we said we will train every university in the world that would want to do ECHO, every not-for-profit that would want to do ECHO. And currently, every major university in the United States has an ECHO project. University of Washington, UCSF, University of Chicago, Harvard, Yale, Johns Hopkins, MD Anderson, and all these others. We have 246 hubs in the US, and 70% of the US counties have an ECHO provider. Worldwide, we have 401 hubs, in fact, 4 hubs in Pakistan, and but we also have hubs in New Zealand, Vietnam, Japan, Kyrgyzstan, Kazakhstan, Myanmar, Vietnam, all these African countries, Ireland, Denmark, Germany, etc. Lots in Latin America, and many in the US. These are our hepatitis C hubs. We have 51 hubs in the world. All over the world, we have hubs for hepatitis C, and literally hundreds of thousands of patients have been treated by ECHO, and the cure rates are extraordinarily high. This is ECHO in Argentina, where they, for 437 patients, they in 25 providers in 14 distributed areas of Argentina, 94.3% cure rate. This is ECHO in the VA, where they showed that if the doctor participated in ECHO, the likelihood of getting treatment for that patient was 21.4% versus 2.5% if the doctor was not participating in ECHO. This is again a paper for cirrhosis of the liver, also published in Hepatology in 2018. What they showed was if the primary care doctor participated in ECHO, the risk of death from cirrhosis was half than if your doctor did not participate, p-value 0.003. This is ECHO in Punjab in India. There's an institution called Postgraduate Institute Chandigarh. They published this in the European Journal of Hepatology, where they basically put ECHO treatment in every district hospitals with ECHO. Cure rate 91.6%, have now treated 88,000 patients. This is data of Asad Chowdhury, who's a dear friend, and you can see he has used ECHO, and on the left are all the places he has treated ECHO, and on the right are the SVR rates, and I can tell you without you going over the data that SVR rate on these thousands of patients is greater than 90%. And these are more clinics, again SVR rates, and I'm really proud of the work he has done to treat thousands of patients in rural communities. He's also started this, what I call Project ECHO Youth Ambassadors Movement, he's calling it, and it's a beautiful program to raise awareness in the community, because we cannot eliminate hepatitis C and treat all the rest 5 million patients without broad awareness of the need for treatment. And you heard that from Adil, that a lot of people believe because they're asymptomatic that they don't need treatment. They don't understand the risk from death from cancer, from cirrhosis, from diabetes, from heart attacks, etc. Overall in the world, we have 265 publications, all the way from participation. 214 providers have satisfied 146 publications. Knowledge increases, competence goes up, patient health outcomes improve, and community health outcomes improve. These are in a variety of areas like HIV, diabetes, and many, many other health problems. This is our work in Africa. They are trying to achieve in Africa what we would like you to do in Pakistan. This is for HIV. They have 200,000 untreated patients in Namibia, and these are district hospitals learning to treat HIV. This is the expert team in Windhoek, training them. About 4 months ago, we tipped our entire network for COVID-19, and now I'm really grateful to Asad that he's using the network. But I also want to let you know, Aga Khan has used ECHO for hepatitis C, also has the Liver Kidney Institute, and we really tipped all these systems for COVID-19 to do some training. This is in India, 982 COVID-19 sessions, trained 296,000 workers. Overall in ECHO, as of 2019, we had 236,000 mentees from all over the world, but in the first 7 months in the world for all the diseases, including COVID-19, 622,000 clinicians have participated. Worldwide, we have trained 500,000 frontline workers in COVID-19, and I encourage you to talk to your government to adopt ECHO for COVID-19, not only for education of the people, education of the workers, but also we have a huge challenge coming in front of us in about 8-9 months. A vaccine will come out, and the world has never vaccinated 7 billion people altogether. And we want to use ECHO. ECHO can do this because we have a worldwide network. We want to train a massive workforce in vaccination, in treatment of people, and so that every person has in their home community a healthcare worker, could be a community health worker, could be a nurse who's fully trained on vaccination. That is why the patient should get it, why it is not harmful to them, why should they really, what will be the side effects to them, what is the risk to them and their families if they don't take the vaccine. Once they take the vaccine, when they're having side effects, how should we manage that? And this is where we are very interested in partnering with Pakistan government to do this. In the last 6 minutes that I have, I want to talk about what makes ECHO work and how it can be used for hepatitis C elimination in Pakistan. What makes ECHO work is team-based care. Task shifting is the idea of bringing every human being working at the highest level of his human potential. This in Pakistan for hepatitis C elimination will be community health workers, doctors, nurses, everybody in the health system. How do you do this task shifting? You give them interprofessional consultation, guided practice, and mentor-mentee relationships. If you give them these three things, all human performance will improve. ECHO is also a social network. It produces joy of work. In fact, Asad Chowdhury has got data to show, and I hope he can make a comment on that, that professional satisfaction of his learners has gone up with ECHO. Technology reduces the cost of collaboration. In the US government was able to reduce the cost of training an HIV provider in quality improvement from $800 to $40 with ECHO, and they could do it better. Force multiplication is the idea of 10 times. Demonopolizing knowledge means every one of you should start an ECHO to demonopolize your knowledge. This will be your zakat for your country to help the country eliminate hepatitis C and save 1 million lives. All teach, all learn is the idea that you will basically also learn from the rural providers, because they will bring the cultural, rural circumstances, the economic barriers, the human resource barriers, and together you will solve this problem. ECHO is a movement to change the world, and I'm inviting you all to join this movement, to join me in improving liver disease care, gastroenterology care, COVID-19 care in India, so in Pakistan. So what does zakat mean for ECHO? Usually when you do zakat, you give away a portion of your wealth to the poor. What happens when you do that is you are left with less wealth. If you give away half your wealth, you are left with half. But in ECHO, when you democratize your knowledge and you engage the ECHO model for all teach, all learn, which is the best form of zakat, you actually become richer because your knowledge doesn't go down. The physics of knowledge is such that when you share it, it grows instead of reducing. So let me go to a lighter topic. How many of you have seen the movie Godfather 1? Can you raise your hand if you've seen the movie Godfather 1? I'm looking to see who's raising their hand. Okay, very few have seen the movie. So what I want to show you is, this is a film, this is a photograph of Marlon Brando, who was the protagonist in Godfather 1, and Francis Ford Coppola is talking to him, who's the director. And Francis Ford Coppola is asking, how do you make a great movie? This is Marlon Brando is asking him this question. And Francis Ford Coppola is asking, you get everyone to agree to make the same movie. This is a very important point if we want to eliminate hepatitis C in Pakistan. Everyone should agree to make the same movie. If all of you agree to make the movie of eliminating hepatitis C in Pakistan, then it will happen. And we would need to do 5 things. We would need to educate everybody. You would need to diagnose everybody. You would need to link to care. You would need to vaccinate them for B, etc. You would need to treat them and follow up. And you would need to do them for 5 million people. So what is required to do this for 5 million people is on the left side of the slide. I call this the 5 conditions of collective impact. First, you need a common agenda. We should agree we want to do that. We must have a shared measurement strategy. We must have reinforcing activities like ECHO does, weekly training sessions. There should be continuous communications with all teach, all learn. And ECHO can be the backbone of that operation. And we will give you any level of assistance you need from the United States to do this work. ECHO fits in with the UN Sustainable Development Goals. Goal 3 is good health and well-being. Gender equality, because women will have a harder time in Pakistan to get hepatitis C treatment because they cannot travel as much, and reduce inequalities all across Pakistan. This is our team, and I want to thank our team, and I want to thank Asad and Adil, and most importantly, the American College of Physicians for inviting me actually to share this topic with you, which is very dear to my heart. My parents grew up in Pakistan, and the country is very dear to me. And my mother was in Gujranwala, and my father was in Kohat. And eliminating hepatitis C in Pakistan is something that I have a very, very dear need for, and ask for your help in doing it. Thank you.
Thank you, Dr. Arora, for a nice talk. Mic is over to Dr. Asad Chaudhry, please.
Thank you. Thank you, Dr. Sanjeev, for an excellent talk, and Dr.
Thank you very much.
You know, I have to leave because I feel so sorry I have to leave, but somehow they only blocked the hour of my calendar. But I apologize to all of you for leaving. But Asad Chaudhry can take any questions on my behalf. But I just want to offer our complete support from the US to help you in any way we can. Thank you.
Thanks.